Hi, I'm fine. Thank you for coming to this webinar. Today, we will be talking about breast imaging essentials, technique, and interpretation. And firstly, I would like to acknowledge the traditional custodian of this land. I pay my respect to the elders, past, present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. I will be covering a few things today, including prevalence and incidence of breast cancer, some risk factors for breast cancer. I'll go through all of the breast imaging modalities and when do we use these modalities. And then we'll go through breast densities, BI-RADS classification of breast lesions, and show you a few examples of imaging-guided biopsy. And then I'll give you several messages to help you with your practice. Breast cancer prevalence. So breast cancer is the second most common cancer in Australia, and it is only after prostate cancer. Every year we have approximately 20,000 new cases in Australia. And when we look at the incidence, you can see that the incidence of breast cancer increases with age, and it peaks around 65 to 75 years of age, and it slightly goes down with age reaching more than 85 years of age. It is estimated that 1 in 8 women will have breast cancer by the age of 85, and that's significant. Going through some risk factors for breast cancer, we know that genetic factors play a big role, and there are several genes that are known to be associated with increased breast cancer risk: BRCA1, BRCA2, and CDH1 and TP53. These are common ones. Family history, as you can see, the more first-degree relatives with breast cancer, it increases the breast cancer risk by up to 4 times the risk with more than 3 relatives. And personal past history of breast cancer is obviously a high risk factor for developing recurrence and also contralateral breast cancer. Lifestyle factors, including HRT, is thought to be also associated with increased risk of breast cancer. It depends on the type of HRT and dosage and how long the patient has been on it. And obesity and alcohol are also thought to be risk factors for breast cancer. Lastly, dense breast tissue increases breast cancer risk by up to 4 times with extremely dense breast tissue compared to fatty breast tissue. We will be going through the breast density in more detail later on in this talk. Sorry, by the way, if you have any questions, we will be taking questions throughout the talk. If you want to pop them in the chat, I'll answer them at the end of the presentation. Breast cancer modalities. So we are all familiar with mammogram, ultrasound, and MRI breast, but there's a new sort of later development of a contrast-enhanced mammography that I'll touch on a little bit today. If we look at 2D mammogram, the detection rate is approximately 7 per 1,000 cases that we read. By adding 3D tomosynthesis to the conventional 2D mammogram, we can increase our detection rate by 1.5 cases per 1,000. If we look at using contrast-enhanced mammography, the detection rate more than double compared to standard routine screening mammogram without contrast. I'll show you some examples throughout the talk. Ultrasound is often used to supplement routine screening mammography, and it increases detection rate by 3 to 4 per 1,000. And MRI breast is often reserved for the breast specialist, and it is the best test and the most sensitive test in terms of detecting breast cancer. It picks up to 18 cases per 1,000. I'm going through all of the different types of breast imaging modalities so you could understand the different types of breast imaging modalities. So this is a routine 2D mammogram. So each breast is taken from medial lateral oblique, from side to side, and from cranial caudal length, top through superior and inferiorly. And we do the right breast, right MLO view, left MLO view, right CC view, and left CC view. And this is what we call it a routine 2D screening mammogram. And in Breast Screen Australia, all patients are eligible for this routine 2D screening mammogram. It is free and no referral is required. It is for asymptomatic women only. If your patient has symptoms, please send them to Diagnostic imaging in either public hospital or private practice, because screening takes a long time, and there's a few weeks before the patient's being screened and the mammogram is being read. It means delayed diagnosis. So it is for asymptomatic women between 50 to 74 years of age. However, patient 40 to 50 years of age and more than 75 years of age are eligible for every 2-yearly mammogram. They just don't get a reminder letter to come to have their screening done. But they can turn up if they would like to have it done. So after routine 2D mammogram is done, the scan will be read by 2 radiologists, and we will classify them as normal or abnormal. The abnormal mammograms will be recalled. The patient will be recalled for assessment. And also note that breast density is not reported at breast screen because they just don't have the, it's not available yet. And once the patient's being recalled to assessment clinic, we would do 3D tomosynthesis to work up what's abnormal, and can we tell that it is normal after assessment. If there is any suspicion of a focal abnormality, we will perform targeted ultrasound. So it's not comprehensive assessment with ultrasound, only targeted region. This is what breast screen is able to provide. And if there is a target lesion, then ultrasound or stereotactic biopsy will be performed for further evaluation. So I'm going to talk about 3D tomosynthesis and how is it different to 2D mammogram. It is done in, it's a technique to assess the breast tissue in thin layers, typically 1 millimeter slices, and it's used to help us see what's inside the breast in detail. It often shows the abnormality better compared to 2D mammogram, and it helps us to locate the lesion. Is it in the lateral breast or medial breast, superior breast or inferior breast? It gives us more information than the 2D mammogram. Here's the 2D mammogram I showed you earlier, the same patient, and this is her right breast tomosynthesis, 3D tomosynthesis. So I'm going to play a video. This is the lateral view, and see the slices goes through from medial to lateral, and this is the CC view. You can see the video playing slices through from the superior breast to inferior breast, which is the cranial caudal direction. I'm sure some of you can see that there is a mass lesion that is better seen here compared to 2D mammogram. And you can see the lesion better compared to 2D mammogram. So in diagnostic mammogram, diagnostic setting in public hospital or private hospital, 2D mammogram and 3D tomosynthesis are done together to increase the sensitivity of breast cancer detection. And it is different to screening mammogram done at breast screen. And imaging requests from GP or breast specialist is required. And there are several eligible criteria for Medicare rebate. And now I'm going to do a poll question to see if you know the Medicare rebate criteria for diagnostic mammogram. So which of the following clinical symptoms are eligible for Medicare rebate for diagnostic mammography? A, palpable lump. B, focal pain. C, nipple discharge or skin changes. D, family history of breast cancer. Or E, all of the above. I'll wait. Please put your answer in the poll. Okay, I think all of you know the answer is E, all of the above. It is important to know the Medicare rebate criteria so that when you request a mammogram, a diagnostic mammogram for your patient, you put down the correct clinical indication to help your patient and help us know where we are looking at the area of concern. And now I'm going to go through this Medicare rebate so that everyone's clear that Medicare rebate is funded for focal symptoms, any suspicions of breast cancer, if your patient has any personal past history of breast cancer or any strong family history of breast cancer. However, it does not rebate for screening mammogram because that's done at breast screen. And if you have general symptoms and general lumpiness and follow-up benign lesions, unfortunately, there is no Medicare rebate for these indications. So I'm going to talk about contrast-enhanced mammography a little bit so that you know what this test is about. And if you think your patient needs this test, you could have a think about ordering them or referring to the breast surgeon. So contrast-enhanced mammogram is basically 2D mammogram and tomosynthesis, and we do an additional contrast part of the examination. It is like mammogram with contrast. We know that tumor have neurovascularity. It means when we give contrast, the contrast leaks out of the blood vessels and it diffuses within the tumor. And that's what we look for when we assess with contrast. This is just the same as when we do staging CT for cancer staging. We give contrast to pick where the tumors is and help us with better, more accurate diagnosis. It is a good alternative to MRI breast. It is slightly more accessible. However, it is not widely available throughout the country. It is less expensive compared to MRI breast, and there is currently no Medicare rebate for contrast-enhanced mammogram. So either a breast specialist refer it or a GP refer it. The patient has to pay for the test. However, the mammogram and tomosynthesis component and the ultrasound component can be is rebatable if there is correct or appropriate clinical indication. So what we do with contrast-enhanced mammogram is we check patient's renal function and make sure there's no contrast allergy or anaphylaxis, just like what we do with any CT staging when we give patients contrast. It's the same contrast, it's the same amount, and the same what we do for CT staging scans, and it's the same for contrast enhanced mammogram. So we insert a cannula, give 100 mils of iodinated contrast. We wait 2 minutes for the contrast to perfuse throughout the breast, and then we have 10 minutes to perform all the 4 views that we want to we routinely do, which is the right MLO, left CC, right CC. And I'll show you an example of what it looks like. So remember our patient who had the 2D mammogram, and then this is the 3D tomosynthesis, and here's the contrast enhanced mammogram. So in one single compression, so the patient get positioned for the right breast, and we perform a view from medial lateral oblique. The mammogram machine will take a picture of the 2D image and a 3D tomosynthesis, and it will come up with a contrast image. Same again, this is the right CC view, same 2D mammogram. You could see a vaguely slightly denser mass here compared to the very dense breast tissue, and the tomosynthesis here, which shows it slightly better compared to 2D, but again, contrast enhanced mammogram shows it very, very obviously, vivid enhancement. This is what you get with routine contrast enhanced mammogram, not the malignancy, but this you can see background parenchymal enhancement throughout both breasts, and the malignancy will enhance more densely compared to the background. Okay, now we have poll question number 2. Which of the following is false? A. Contrast enhanced mammography increase sensitivity of breast cancer detection. B. Contrast enhanced mammography is helpful in patients with dense breasts and strong family history of breast cancer. C. Contrast enhanced mammography can only be requested by breast surgeons. D. Contrast enhanced mammography should be avoided in patients with renal failure. Please put your answer in the poll. Okay, I'm sure you know the answer is C, because there is no Medicare rebate because of limited services around the country. It is often reserved for breast surgeons. However, if you have a patient with dense breasts and strong family history of breast cancer that you think is important to exclude breast cancer, you could request contrast enhanced mammography. You just have to find out from your local imaging providers what is the wait list, and if they do the test, and discuss the cost with your patient. As you can see here, contrast enhanced mammography has higher sensitivity and specificity compared to the 2D 2D mammograms. And now we have ultrasound. Ultrasound is often done to complement mammogram, and it is much more sensitive to detect breast cancer in a younger age group, because their breast is often very dense, and it doesn't have radiation, and it helps us to evaluate if the lesion is cystic or solid. Does it have malignant features, or does it have benign features? It is very helpful. If we see the lesion that looks suspicious on mammogram, then we want to find it on ultrasound so that we could take samples using ultrasound guidance. And mammograms does not cover the axilla very well. So ultrasound is often used for assessment of lymph node. So this is our patient with the mammogram and contrast mammogram, knowing that the malignant mass is in the upper outer quadrant. We could target this area to do an ultrasound, and here it is, right by 11 o'clock, 3 centimeters from the nipple. Here's the mass with irregular margins, hypoechoic, suspicious for breast malignancy, consistent with what we see on mammogram. And we can see the right axilla quite well, and can assess the cortex of the lymph node if the lymph node has lost their fatty hilum or thick cortex, then it is abnormal, and we would also sample that. It's a different types of contrast. It's gadolinium contrast. So a patient with iodinated contrast allergy can have MRI breast. So what we do is the scan takes about 10 to 20 minutes, depends on what protocol the radiologist decide to use. We would like to often do a T2 sequence like this one to look for any edema. As you can see, the skin in this breast is thickened and the breast is edematous. And this is a T1 sequence. You can see the skin is thickened, and you can see the mass better with a dark susceptibility artifact from a breast marker from recent biopsy. And after giving contrast, you see the mass can be seen in all three planes. This is an axial plane, coronal plane, and sagittal plane. You can measure the mass accurately, how extensive it is in the breast. It is important to help breast surgeon plan before surgery whether it's conservable or not conservable, which means a mastectomy. These are tools that we use to help surgeons with their surgery. And MRI breast also gives us dynamic information. So once we give contrast, we do lots of scanning to see how fast the cancer enhances, and we can map out how the contrast retains in the tumor or washes out. And we get a lot of information on MRI breast, and it is a fabulous test. Now we've gone through all of the breast imaging modalities. Now I am going to talk about breast density and show you some examples of how breast density impact breast cancer detection. And firstly, so breast density can be categorized by BI-RADS classification of A, B, C, D. BI-RADS A is less than 25% of fibroglandular breast tissue. This very dense tissue is fibroglandular breast tissue. The dark areas, fat. So BI-RADS A is fatty breast. BI-RADS B is scattered fibroglandular breast tissue. It's patchy areas of fibroglandular breast tissue. And BI-RADS C is heterogeneously dense breast, which is 50 to 75% breast tissue. And BI-RADS D is extremely dense breast, more than 75% dense breast. Breast density reporting I think, is mandatory in private practice. I do it personally for every one of my patients. It's important because it means the patient has increased risk of breast cancer, and it means the study is less sensitive compared to patient with fatty breast. There is different types of way to report breast density. It could be qualitative, which means using eyeballing how much breast density there is, or we can use a quantitative method using software called Volpara or Quantra. And as you can see, the denser the breast, the sensitivity of breast cancer detection reduces up to 50%, down to 50% with extremely dense breast tissue. And I will show you why by showing you examples of each types of breast density, and each of these patients that I'll show you have a breast malignancy, and we can see how hard it is to detect them as the breast density increases. So this is an example of BI-RADS A fatty breast tissue. I'm sure everybody can see a mass in the right breast lower outer quadrant. The left breast is fatty. And on the targeted ultrasound of the right breast, 9 o'clock, 4 centimeter from the nipple, there is a spiculated mass with echogenic rind and internal vascularity. All of these features are consistent with a breast cancer. Now, breast density B, scattered fibroglandular breast tissue. You can see it's getting harder to tell because there's increased density here. Some people have asymmetrical breast fibroglandular breast tissue, but this is a picture of this is a contrast mammogram showing enhancing lesion in the upper breast and outer breast, left breast. Knowing that it is in the upper outer quadrant, we could then do ultrasound targeting that area and find a corresponding mass, and it has been biopsied and proven breast malignancy. You can see it's just camouflaged in the area of dense breast tissue. So now we have breast density C. It is heterogeneously dense breast in both breasts. And you can see this patient had previous breast cancer with surgical clips in the right breast, some axillary surgical clips from previous axillary dissection or sentinel node biopsy. In the left breast, it's just scattered heterogeneously dense breast. Vascular calcifications, these are benign, just very busy. This is her contrast mammogram. You can see an enhancing mass deep to the surgical scar. There's also a little bit of enhancement in the central left breast. By using contrast enhanced mammogram, we can target our ultrasound to the area of interest, which is deep to the surgical scar and in the central left breast. Indeed, we found a recurrent breast cancer in the right breast at 2 o'clock, 6 centimeters from the nipple, which is in the lateral submedial breast, and also a suspicious mass in the left breast, 10 o'clock, 1 centimeter from the nipple, and only because we know where to look. Okay, now we have density D, extremely dense breast tissue. May be able to see some extensive pleomorphic calcification here, and contrast enhanced mammogram, it is very obviously abnormal in the left breast with some mass and non-mass enhancement throughout the left breast. These are the left breast was sampled and proven to be extensive DCIS with areas of invasive disease. So that was breast density and contrast enhanced mammogram. And we can see that with extremely dense breast tissue and heterogeneously dense breasts, without contrast, it's definitely challenging for even breast radiologists to detect breast cancer, which just simply cannot see through dense breast tissue. Ultrasound, complementary screening breast ultrasound certainly helps with increased detection rate. But with this type of patient with extremely dense breast tissue and family history of breast cancer, you could consider contrast enhanced mammogram or MRI breast for a significant increased breast cancer detection rate. So BI-RADS reporting system, this is for when we find abnormal lesion either on mammogram or ultrasound or MRI, we give them a category to help management. So in breast screen, where I work in Victoria, we only use category 1, 2, 3, 4, 5, whereas BI-RADS classification has 0 and 6. 0 means incomplete assessment. We need to wait for previous images to compare without before we can decide to biopsy any lesion. And 6, BI-RADS 6 means the lesion has already been biopsied and proven to be malignant. In between, so 1 means a normal mammogram or normal breast ultrasound. BI-RADS 2, the lesion is benign, such as cyst or stable fibroadenoma over a very long period of time. BI-RADS 3, we find a fibroadenoma, but we don't know that it's stable, or is it going to be increasing in size? Is it a phylloides tumor? So we could do a BI-RADS 3 to have then recommend follow-up ultrasound in 6 months to ensure stability. BI-RADS 4 can be subdivided into 4A, 4B, 4C, depending on how suspicious the abnormality look. 4A is only approximately 2 to 9% malignancy. B about 10 to 40%, 49%, and 4C is high suspicion of malignancy. And BI-RADS 5 is highly suggestive of malignancy when we see a spicular mass and with multiple enlarged lymph node. That is a BI-RADS 5. When we radiologists allocated a BI-RADS 4, A, B, C, or 5, ultrasound or stereotactic guided biopsy is often recommended. So briefly showing you how biopsy was done. We can do it under ultrasound guidance, mammogram guidance, or MRI guidance. So this lesion here, you can see on ultrasound, we have a needle approaching it, and we can take a sample through the lesion. That's how we use ultrasound to guide us to take some sample using a 16 gauge or a 14 gauge core biopsy needle, and we send that off to the pathology. It's very low risk. The main risk would be bleeding, bruising, and infection. So, quick example of mammogram guided biopsy is usually done for microcalcification because we couldn't see that on ultrasound. We put a needle and take some images, making sure it's the right area to biopsy, and then we take some sample and put it into the X-ray machine to take an X-ray of the specimen and prove that there are several microcalcification in the sample, and then send it off to the pathology. This is just a quick example of MRI guided biopsy. You can see an MRI enhancing abnormality. We will have to do ultrasound and mammogram before to check that this is not seen using mammogram guided guidance or ultrasound guidance. If we can't see them, then we would recommend MRI guided biopsy, and the needle goes in the area of enhancement, and we take some sample there, leave a clip in. This procedure is usually referred by a breast specialist. So biopsy markers, just briefly touch on about this, because often when we say to the patient, we need to leave a little biopsy marker, a lot of patients will have some resistance to having any metal clips living inside their breast. It is a tiny surgical grade metal clip, as most of them are titanium. It is can be inserted under stereotactic guidance, ultrasound guidance, or MRI guidance. Comes in different variety of shapes. We place them in the breast for multiple reasons. So sometimes a small lesion can become quite difficult to visualize after biopsy due to some hematoma. The lesions just collapse, and we need to mark the spot so that we can identify the area again. If the pathology has returned any atypical cells or malignancy, then we need to find the same site for the surgeon to excise. And other common indication to leave a clip is when there is a malignant mass and the patient is going to have neoadjuvant chemotherapy before surgery. The tumor often shrinks, and often they are completely gone, and we only have the marker to X mark the spot of the tumor, and that's where we will guide the surgeon to remove the tumor bed. And these markers are so small and they're not magnetic. They are titanium, and your patient can have MRI scan and MRI breast. We often do that MRI after inserting clips, and you can reassure your patient that these markers are not going to set off the alarm at the airport, and nobody needs to know about this metalware apart from the breast surgeons and the breast radiologist. Examples of different types of clips in the breast on mammogram. This is a wing shape one, a ribbon shape, and a twill, a circular one, a coil shape, and we can insert it on the mammogram or ultrasound or MRI. Okay, we nearly finished with the talk, and just a few key messages for you. So when you see a patient and you're clinically concerned of breast cancer, please send them to diagnostic imaging, either public hospital or private hospital, wherever you can get your patient in quickest. Don't send them to breast screen, because there's many weeks of waiting, and it means delayed diagnosis. On your request form, please write bilateral mammography. You can write tomosynthesis if you like, but in the diagnostic setting, it's always done. The 3D tomosynthesis is almost always done together. And with the breast ultrasound, if you are not so concerned, you can put plus or minus and let the radiologist decide. Or if you're really concerned, you can write and breast ultrasound. So if you want it done. So please write specific symptoms. If your patient has focal symptoms, please put it down for Medicare rebate purpose. And if there is clinical concern of breast cancer, please don't be afraid to put down question of breast cancer. It just means that when your patient comes to book their scan, it can be triaged faster and can give out urgent spot. And please write urgent there. And if you want us to call you back with the result, please write it down, put your number down. We will call you back urgently. And so when you see a patient with dense breast, extremely dense breast, and strong family history, if they qualify to have screening MRI breast, that is the best test and the most sensitive test. And refer your patient to the breast surgeon, and they are eligible for MRI breast screening. If your patient has strong family history and not strong enough to qualify for MRI rebate for MRI breast Medicare rebate, you could consider sending a patient for contrast enhanced mammogram. However, you need to check with your local providers to see if they can provide the service, and discuss with your patient. And I strongly encourage you to discuss breast density with your patient. Unfortunately, you won't get the information from the breast screen information. They don't give it to you. But if your patient has private screening before, the information should be in the report. Also, I recommend having all imaging done in the same imaging provider, because it is very difficult for us to chase previous imaging. And if there is a new patient, we have to work up all of the breast changes. And without comparison with two previous, we may not be able to recommend the most appropriate test. And remind your patient to bring their previous imaging when they go to a different imaging provider, especially when they come for biopsy of their breast lesion and we don't have previous to review. It might delay the biopsy for your patient. That's the end of my talk, and I'll have a look at your question and I'll answer. Thank you.
Thanks, Kwan. We've got some questions from the audience. So our first question of the night is there any difference in regards to radiation between breast screening imaging and MRI?
Yes. So firstly, MRI is not radioactive, and it's using a magnet. I think so ultrasound is also not radioactive, not using radiation. So standard 2D mammograms that breast screen performs, assuming that's one, it's about 3.5 milligray. With tomosynthesis that we do, the 3D tomosynthesis, it's about 4.5 milligray. And with contrast mammogram, it's about 5 milligray. We see about 30% more radiation with contrast mammogram compared to 2D mammogram.
Great, thank you. Our next question is, what is the detection rate if ultrasound alone is used to screen for breast cancer?
I would say, I don't know the statistics, but I would, from my experience, using ultrasound alone is going to be a significant decreased detection rate compared to mammogram. With young patients less than 35 years of age, mammograms would just show dense breast tissue. So it's the first choice of screening for these group of patients would be ultrasound. Over 35, we would recommend mammogram and ultrasound, because mammogram would detect microcalcifications that ultrasound cannot pick up. Also, ultrasound is very operator dependent, and I'll give you an analogy. It's like you're wearing a goggle in the Great Barrier Reef and trying to find Nemo. You don't know what you're going to find. So a mammogram will give you a big picture and let you know where to concentrate to look for the abnormality.
All right, our next question, there's the two in one. So does smoking increase the risk for breast cancer, and do breast implants present a problem for mammography?
Yes, I think smoking has a slight increased breast cancer risk, but it's dependent on the duration of smoking and how many pack year history, and the more the history of smoking, the higher risk it will be. And for the next question, so what's the next question again?
The next question was, do breast implants present a problem for mammography?
Yes. So with the breast implants, mammograms is a bit more challenging because we have to be careful not to compress the breast too hard. Also, we have to push the breast implant back so that we can only image the anterior to mid breast, and the lateral breast may sometimes get missed, not imaged. Also, with ultrasound and mammogram, breast implant assessment is quite tricky. We can only assess the contour, we can assess whether there's fluid in front of it, because the breast implants is made of silicone mostly. The ultrasound cannot penetrate through the implant, so it means MRI breast is the test to assess for implant integrity, and it makes the assessment challenging for radiologists.
Our next question, is there a role for screening 3D breast tomosynthesis plus or minus ultrasound for women with dense breast tissue, regardless of family history of breast cancer?
Definitely. I think when your patient has dense breast, 2D mammogram is, as I said, it's about 50% of the detection rate compared to breast density A. However, at breast screen, we currently cannot offer 3D mammogram screening, and the only way to get the test done for your patient is going privately, or when there is abnormality picked up in public hospital diagnostic setting.
Next question. In the original figures on detection rates per 1,000, what does the denominator mean? For example, if MRI has 3 times the detection of mammogram, does that mean mammogram misses 2/3 of breast cancers?
Yes, so per 1,000 mammograms we read at breast screen, we pick up about 7 breast cancer. With contrast mammogram, it double the amount, which means it's not because the breast cancer is not there, it's because dense breast tissue obscure the lesion and we are unable to see through the breast and diagnose it. And MRI is very, very sensitive when it's picked up very small cancer that is enhancing, because we are able to see the breast in 3D reformats and using multiple different kinetics and signals to help us detect very small cancer and very early cancer.
We've got another question here. So could we use MRI as a screening tool instead of breast screening mammography?
Yes, for dense breast tissue, that's what the USOVI guidelines has recommended. For extremely dense breast tissue, screening MRI is recommended every 3-4 years, but we cannot provide this service in Australia at the moment, and it is not rebatable.
Perfect. That's all we have time for this evening. Thank you, Kwan, for your presentation. Thank you, everyone, for joining. Please stay online to answer the evaluation survey. So that survey is really important in helping us improve these sessions. Again, thank you all for coming.
Thank you.